Thanks, Debbie, and thanks again to our sponsors for allowing us to put on this program. And as before, for the best of UEG and American College of Gastroenterology ACG meetings, we're going to focus this on clinical trials of new therapies or strategy trials that might direct how we use or how we monitor therapies in the future. And obviously, it's a really exciting time in the field of inflammatory bowel disease because we have so many new mechanisms of action coming online. And so this rather complicated slide we've shown before, and I'm not going to spend ages going through the immunology of inflammatory bowel disease, but just to highlight where some of these MOAs work. And of course, we're very familiar with the anti-TNFs. They mop up soluble TNF, they bind to cells expressing TNF on the membrane and cause apoptosis, and they impact aspects of both the acquired and innate immune system. We are using vedolizumab, the anti-alpha-4 beta-7 integrin, and as many of us know, that blocks the recruitment of activated leukocytes from the circulation into the lamina propria. We're also using ustekinumab, which blocks P40, stopping signaling through both IL-12 and IL-23. And this has an impact on the way that the innate immune system converses with the acquired immune system, changing the differentiation pathway of lymphocytes. It also has an impact on epithelial responses. Soon, we will become very familiar with a new class of drugs, the anti-P19s. These only impact signaling through IL-23, and they're very much more specific at preventing the differentiation and function of effector memory lymphocytes, which secrete IL-17. We're also I think now most of us have got in clinic, or certainly been NICE approved, drugs that impact signaling through the S1P pathway, and among other actions, S1P is a receptor that traps lymphocytes in the mesenteric lymph nodes, preventing them entering the circulation. It probably has much wider effects on both the innate and acquired immune system. And then finally, we've got 3 JAK inhibitors now in our clinical practice, filgotinib, tofacitinib, and upadacitinib, with more on the way. And JAK inhibitors are small molecules that bind to the JAK receptors on the cell surface of lymphocytes, and actually also some monocyte macrophage populations, and block cytokine signaling. And so there is really a wealth of new drugs available. And we're going to run through those in a little bit, but I'm going to start with some of, I think, some of the really impressive treatment strategy trials that were presented. And perhaps the most important at UEG was REACT-2. So the REACT trials, there's been REACT-1, and now there's REACT-2. The REACT trials don't randomize individual patients to treatment strategies. They randomize practices, so hospitals or clinics, to individual treatment strategies, and then all consecutive patients seen within that clinic get managed by that strategy, and then you compare the outcome of those patients after a period of time, in this case 2 years. So REACT-1 looked about escalating treatment based on the presence of clinical symptoms compared to standard of care. REACT-2 is comparing using clinical symptoms to drive treatment escalation, comparing it to using endoscopic ulceration to drive treatment escalation. So here you've got the 2 algorithms on the slide. On the left, we've got the standard of care, where treatment was step-up based with escalation based upon a Harvey-Bradshaw, so clinical symptoms only, and patients went through steroids, then azathioprine, then adalimumab, then weekly adalimumab, etc., if they had active clinical symptoms. When, if they were in remission, they sort of remained on their current treatment. And on the right-hand side of the slide there, you've got the early intervention in which patients had their treatment escalated based on the presence of endoscopic ulceration, which was defined as any ulcer at least 5 millimeters in size. And so patients had endoscopy. If they had active ulceration, they started adalimumab combination therapy with azathioprine or methotrexate, and then if they had ulceration later on, they escalated the dose and perhaps even added in steroids. Now, the primary endpoint of the trial was development of complicated disease behavior over 2 years, which included requirement for hospitalization, requirement for surgery, disease progression, or treatment-related complication. And it's really important before we look at the results to understand the patients that were included in this trial, because this was not taking patients early in their diagnosis, naive to treatment, and starting them this protocol. This was just looking at consecutive patients within these practices that were all managed in this defined way, either the standard way or the top-down escalated based upon endoscopic ulceration. As it happened, the median disease duration of these patients was about
11, 12 years.
Yeah, 11 or 12 years. And only a small percentage of them had active disease at baseline, and some of them had previously been exposed to an anti-TNF. And so when we looked at the primary endpoint, which, as I said, was CD-related complications at 2 years, you can see here there's no difference in terms of the development of those complications between those two treatment strategies. The lines are pretty much parallel. And of course, this may sort of signal that this concept of a treat-to-target approach based upon endoscopy maybe is not effective. But I think there are some caveats to that, because, as I said, a lot of these patients were some way down their disease journey. Many of them had relatively quiescent disease. And so they did do a sub-analysis where they looked to see what would happen if they only included patients who had endoscopically active disease or an elevated CRP at baseline. And here you can see that you do begin to see a difference between escalating treatment based upon endoscopy in red compared to standard care where you escalate based upon symptoms in blue. And you can begin to see a treatment benefit with reduced complications in the treat to target group.
Yeah, it's really interesting, isn't it? And I guess, you know, this result doesn't tell us that much, in that it's not surprising that if you treat active disease aggressively, then you tend to do better. But you know, the difficulty whenever you're designing trials like this is one of the many difficulties. What is your target? You know, we pick this somewhat arbitrary, an ulcer greater than 5 millimeters in size, and you know, you think, well, if you're to reduce it to the absurd, then of course, what would 1 6 millimeter ulcer mean in an entire ileocolonoscopy? And you know, it's the difficulty with these trials. You kind of have to come up with criteria.
And of course, the great distinction between this and a trial like CALM took a group of people who were very early in their disease, and therefore their ulceration was very much early ulceration. You know, for this cohort of patients with a long median disease duration, you've no idea whether the baseline ulcer that justified early introduction of top-down therapy had been there for 10 years anyhow, without progressing at that point.
Right.
So it is. I think this is a difficult trial, perhaps, to read too much into.
And yet it does. I think it does support the principle that, you know, the drum that has been being banged for many years, that you should think beyond symptoms, particularly in active disease, and active disease here being defined by CRP as opposed to by symptoms.
Yeah, I think that's a fair point.
I think it's over to me, isn't it? Yes, okay. So I'm just going to shuffle over a little bit. So ultrasound, and you know, those of you that have tuned in over the years to our webinars and or have been to meetings will have seen more and more abstracts about ultrasound in inflammatory bowel disease coming out over the years, and finally this form of imaging is starting to penetrate the UK, and I think will continue to do so over the coming years. More and more people are starting to get interested in getting trained in it, and I think it's one of the reasons why we keep showing things, because I think it probably is an advance in how we do things. This was a nice little study from Emma Calabrese, who's produced abstracts over the years. She's Italian and does some very nice work, and trying to work out whether early ultrasound assessment of people will predict how they do over time. And I think this is useful because if we're thinking about Crohn's disease, then of course you're never going to do a colonoscopy at 3 months. If you're lucky, you might do one at 6 months. You'll aim to do one at a year, by which time, of course, people have been on drug by definition for a long time. And if there's non-invasive ways of doing this, then I think that represents a benefit, a potential benefit for the future. The same goes for ulcerative colitis. Of course, it's easier to look inside, but ultrasound's a useful modality to look at UC, and an early ultrasound could be a predictor of later outcome. That's exactly what this study is looking at. Can early ultrasound predict later outcome? And it uses 3 main methods of assessing activity. So bowel wall thickness, which I think is consistently coming across in several trials to be a key measure of disease activity and a responsive measure to successful use of medication, and then various other bits and pieces you can see in the middle there, a composite of lesion extent and echo pattern, etc. And then at the bottom, blood flow, so Doppler signal using a score called the Limburg score, which I'm happy to admit I know very little about. And you can see that their definitions were transmural healing was normalization of all of these parameters. Responder was improvement in 2 parameters, including bowel wall thickness, and the delta bowel wall thickness, not surprisingly, is the change in the bowel wall thickness between baseline and 3 months. And then they looked to see what the outcomes associated with these patients, who I have to say were all starting one of the biologics, anti-TNF, Vedo or ustekinumab. And the first thing they found was that the change in bowel wall thickness over 3 months of treatment was associated with outcome at 12 months. That's this graph on the left-hand side here. You can see there was a greater decrease in bowel wall thickness in the people who ended up with transmural healing than in those who didn't end up with transmural healing, where you can see the median there is about 0. Then they also looked not just at bowel wall thickness, but in the patients who achieved improvement in bowel wall thickness and in their blood flow score, their Limburg score. And you can see that if you had improvement in both of those parameters, then about half of the patients got got transmural healing, whereas if they didn't have improvement, then the vast majority of patients didn't have transmural healing. So I think putting all this together without getting it into too much detail it's suggesting to us that we might be able to detect an early benefit of therapy with a probably meaningful long-term outcome by using ultrasound early in the treatment pathway, so when you started a treatment. And I said the outcome is relevant. Well, is the outcome relevant? And in fact, this next abstract goes on to look at exactly that. It was a Portuguese abstract, I think, a retrospective abstract of quite a large number of patients, actually, 425, all of whom were starting anti-TNF therapy. And it looks at what happens to them at 6 months. And they divided them into 4 forms of remission, one of which was no remission. So it's not a form of remission at all, really, is it? So they assessed people based on MRI scan and on colonoscopy. And you either had basically healing on both, healing on one, so radiologic healing, but not endoscopic healing, or healing on endoscopic, but not radiological healing. If you had both, they called it transmural healing. And then if you go to the right-hand side, you can see what each of those outcomes was associated with over the preceding 5 years. So you can see, if you look at the red patients who had transmural healing, not many of them ended up in hospital, none of them had surgery, and not many of them ended up with steroids. And if you go to the other end of the spectrum, you see that if you had no remission, that's the purple bar, then you were much more likely to end up in hospital having an operation or needing steroids. And then the other two, endologic remission, were kind of in between. And I guess, actually how those things are defined might sort of drive the outcomes to an extent. But again, I think what this says to me is it's not all about the mucosa.
Absolutely. I think that's very true. And I think it's absolutely true that the more rigorous the endpoint you use, be it endoscopic, be it transmural healing, the better the subsequent disease course will be. But we've got to be very clear that just because an endpoint delivers better outcomes doesn't mean that that should be a target in terms of treat to target. They're two slightly different things, because a target has to be modifiable and you have to know the operating characteristics to drive treatment changes. And I think, to some extent, that's one of the problems that we were just discussing within React 2.
Right. Although it could be a target.
It could be. It could be.
Yeah.
Don't know yet, but it could be.
No.
Oh, there we go. Let's just see if there are any questions. I'm finding it just. Oh, there's my cursor. None yet, but if you've got it, oh yeah,
yes,
here we go. Did they check fecal calprotectin in React 2? It's actually a really good question, and I don't think they did. They certainly didn't drive treatment decisions based upon fecal calprotectin, and they didn't present any fecal calprotectin results during the presentation at UEG. What I don't 100% know is whether they actually measured it. Pete's going to look into that. And we'll maybe just feedback on that in just a moment. I'm going to talk about one of the newer drugs. It is been available through an open access scheme in the UK over the course of the last few months, and some of us have had quite a reasonable experience about it. And I'm going to talk about risankizumab, as mentioned, a P19, so it inhibits IL-23, looking at effectively, I suspect, two quite useful abstracts for where it will fit within our clinical practice in the very near future, which is patients who are quite refractory, either because they've failed previous biologics or because they're quite slow to respond. And these abstracts were presented at UEGW. So first of all, just to run through the clinical trial design, it was a relatively standard design. We're talking about Crohn's disease. There were two parallel induction studies. One only included people refractory to previous biologic therapy. One included a mixture of bio-naive and bio-refractory patients, and they all had moderate to severe active disease with endoscopic evidence of active disease at baseline, centrally read. They were randomized to one of two doses of risankizumab, 12 or 600 versus placebo, and the primary endpoint for the induction trial was at 12 weeks. Those who responded were able to enter the maintenance arm, where they were randomized to either ongoing risankizumab, one of two doses, or drug withdrawal, i.e. they'd received risankizumab in the induction and then they withdrew drug and had placebo in the maintenance arm. Those patients who didn't meet the definition of a response at week 12 were allowed to have a further 12 weeks of reinduction at one of two different doses, and we'll come on to that when we get to the relevant abstract. And if they subsequently responded, i.e. responded after 24 weeks of therapy, they went into the maintenance study, and if they didn't, they came out of the trial. So this first abstract is taking patients from both the induction studies, so we've got a mixed population of bio-naive and bio-refractory. It's looking at the responders who then entered the maintenance trial, and during the maintenance trial, as mentioned, they received one of two doses of risankizumab, or they withdrew drug and ended up on placebo. And you can see here the numbers in total in each group and the numbers without biofailure, so bio-naive, and the majority, so it's about a third bio-naive and 2/3 biofailure, and then looking at the co-primary endpoints, which were clinical remission and endoscopic response at week 52. quite a busy slide, but I'm going to talk you through it because it's quite straightforward, actually. In the rows, you've got 3 different definitions of the endpoint. You've got clinical remission as based on the Crohn's Disease Activity Index. You've got clinical remission as based upon the European definition, which is stool frequency and abdominal pain score. And you've got endoscopic response, which is a fall in Crohn's disease SES-CD by 50% or more from the baseline scope. And then within each bit, you've got 3 columns: failed 1 biologic, failed 2 biologics, or failed at least 3 biologics. The left-hand set are the induction results, and the right-hand set are the maintenance results. And what you can see in green compared to grey is that you did get benefit of risankizumab, however many biologics you had failed at the induction dosing, and the significance was remained as irrespective of the number of prior biologic failures. And that's quite a good signal of benefit in an induction study, given the numbers were small. And then when we come on to the maintenance data, you can see that the benefit is maintained, certainly up until the failed 2 biologics. There may be a slightly lower signal in the failed 3 biologics, and that's where, when you get to the harder endpoints, if you look at bottom right, endoscopic response in someone who's failed 3 biologics, that's when you begin to see a much clearer dose response. Don't forget, some people might say, well, you know, it's not that much better than placebo, but don't forget that placebo isn't really a true placebo arm, because these patients all had responded to drug at induction. The drug has a very long PD and PK half-life, so realistically, you know, they're going to have some carryover drug. I think that's really quite useful data. And what's equally useful is trying to answer a question that comes up all the time: is can you treat someone who's failed ustekinumab, the P40 inhibitor, with risankizumab, the P19 inhibitor? So this was looking at the even smaller number of patients who had previously been exposed to ustekinumab. They were capped at 20% in the phase 3 trial program. And again, here you can see at both induction trials and at the maintenance trial, you can see that upwards of 50% of patients maintain remission on risankizumab, having previously failed ustekinumab.
We've just looked back at our patients that we treated with risankizumab in real life. So we've got 34 or 35.
All of whom will have had to fail ustekinumab by definition, because that was the...
Exactly. And that's exactly the point I was going to make. And in fact, they've not just failed ustekinumab, but they've failed vedolizumab and at least 1 anti-TNF as well. And we see a significant number of those patients responding. So, and of course, in psoriasis, we've seen very much, benefit of P19 over P40 inhibition, haven't we?
Yeah, and I think it makes it really interesting to see the data of the sequence trial, which is the head-to-head risankizumab ustekinumab trial in patients who are naive to both, so they're anti-TNF only failures. And I think that's really exciting data. That's closed to recruitment, so presumably will play out next year. Yeah. Second trial, if you remember, this was a slightly different group of refractory patients. These were patients who did not meet the criteria for response at the end of the first 12 weeks, and therefore were re-randomized to one of 3 doses of risankizumab for another 12 weeks. So these people had 24 weeks of induction dosing and then carried on maintenance dosing. And it's a slightly busy slide, but I'm just going to take you to the third result which is clinical remission. That was the primary endpoint in the US. And you can see that between 50 and 67% of patients achieve clinical remission. So there is a bit of a slow burn in some patients with this drug. It isn't that if they haven't got completely better at the end of 12 weeks, there's no way forward for them. About between a half and 2/3 of patients will be captured by ongoing therapy. Likewise, you can see here endoscopic endoscopic remission and ulcer-free endoscopy. You do see that in a percentage of patients.
Lovely.
Over to Pete for the other P19, or one of the other P19s.
One of the other P19s. So mirikizumab. Mirikizumab, as James just said, another P19 inhibitor, and the closest drug that we have to being available for the treatment of ulcerative colitis, and that's why we're going to talk about it today. So a trial design you're very familiar with a subtle, James making coffee in the background, with a subtle difference, and that's there is only one induction study, and that's because it was a massive induction study, as we'll see in a minute. But then those patients who responded at week 12 were re-randomized 2-to-1 to receive either maintenance with 200 milligrams of subcutaneous mirikizumab every 4 weeks, or placebo. Fairly standard group of patients, disease duration of about 6 or 7 years, about 40% on steroids, about 20% on immunomodulators, and about 35% had failed a biologic or tofacitinib. And isn't that an interesting group of patients? Tofacitinib failures, we'll be seeing more of those over the years. Unfortunately, in reality, too few in this study to get a feel for it. And of course, because of when the study started, no ustekinumab failures in there either. So we've seen this data before. Actually, I think originally presented at ECHO this year, and this is the induction study. As you can see, as I said, a very big study, 870 patients in the treatment arm versus 300 in the placebo arm, and overall 12 weeks of induction with 300 milligrams of mirikizumab was better than placebo. A convincing delta there, more marked in the biologic naive than the biologic failed patients, and in fact didn't quite hit significance there. But we saw that with ustekinumab in Unify, I think, as well, that you had a better response in the bio-naive patients. And I'm not going to go into it in any great detail, but a safety profile that we're becoming familiar with, I think it's fair to say, with P19 antibodies, which probably reflects the safety profile we see with ustekinumab as well. Excuse me. One of the interesting things that Lilly did in this program was look at urgency, which of course is being looked at more and more in particularly ulcerative colitis registration trials. But Lilly actually used a numerical rating score for urgency, which was originally going to be called RUNS, but in fact they decided to change that in the end. No, I thought they should have kept it. It goes along with sort of us calling our studies pants and things like that, doesn't it? But the thing that was good about this was that it is a validated endpoint now, and that means that they can put it in the label and things. So, but I think it just brings to the front the fact that, of course, that urgency is important and we should be thinking about it. And it is perhaps not entirely surprising when you look at the results that bowel urgency and remission of bowel urgency was associated with better outcomes across sort of clinical response, clinical remission, endoscopic remission, as you would probably expect. If we then go on to Lucent 2, so this is the end of 52 weeks, in other words, 40 weeks of maintenance. And remember, these patients have been re-randomized to either drug or placebo. And as James pointed out with risankizumab, and as we've also seen with ustekinumab in the past, there seems to be a sort of a long hangover effect of the drug after induction, because all these patients have, by definition, responded to induction. And that's why I think you're seeing, if you look in the second bar here, a placebo response of maintenance of clinical remission of, approaching 40%. And one of the reasons that's important, of course, is that these drugs will perform differently in network meta-analysis than drugs where you lose response quickly. Compare this with a JAK inhibitor, where you get rapid onset and offset of action, and you will see in the maintenance arms of re-randomized responder trials, you'll see a very different picture, and that will interfere with network meta-analysis. And I think, James, you told me something I didn't know last time, which was that did you say that different network meta-analyses are being done for different drugs? Or different sorts of drugs
within for comparison. NICE, yes.
Within NICE. Okay. Oh, that's good. I didn't know. That's good to hear. And the other thing to point out, of course, here is that you're seeing positive endpoints across the range of outcomes that we think are important. Endoscopic remission, of course, is a different definition to endoscopic healing, because the definitions have changed over time. And then, of course, as with most studies in ulcerative colitis nowadays, there's also combined endpoints of histologic and endoscopic remission. How important these different endpoints are, again, I think it actually goes back to what you were saying earlier about targets. And an endpoint is not the same thing as a target.
Absolutely.
I think it tells us the drug is working, and the more endpoints it's positive in, the more convincing it is the drug works.
And the harder the endpoint is, I suspect the lower the placebo response.
Yeah.
And therefore you can obviously see a delta. And I think one of the bits, I don't know if we've got the slide here, is one of the things I thought was very impressive with the mirikizumab maintenance data was the comparison between bio-naive and bio-exposed. For some drugs, you definitely see a drop-off in efficacy with bio-exposed. And I just showed you the risankizumab in Crohn's data where there perhaps wasn't such a marked drop-off. And the same was true with the mirikizumab in UC data. There really was no difference in the delta between drug and placebo between those who are bio-naive and bio-exposed. And I think that's another really strong signal for the use of this drug in our practice.
And I think, what we see in induction, where there is a difference, is probably about speed of response.
Yes, because they are a slightly slower burn.
Right, exactly. And then bowel urgency over time, obviously. That graph on the left there, the orange bar is the orange dot, sorry, that's mirikizumab. And basically what this shows is that improvement in bowel urgency score. In other words, a drop of 4 is maintained over the 40 weeks, whereas if you're re-randomized to placebo, you start to lose that response. And then if you look at it as a bar graph, you can see the proportion of patients with remission is obviously higher in the mirikizumab treated patients than in those who are re-randomized to placebo. And again, whilst safety is extremely important, obviously, with all new drugs, I'm just really going to summarize this, that apart from injection site reactions, there's probably no difference here between re-randomization to placebo and to drug. And again, I think this fits nicely with our, with our feel for this class of drugs. Should we hit to see if there's any questions? So there aren't any more questions. Please do feel free to ask. In relation to fecal calprotectin in REACT-2, I've looked through the slide set that was presented, and I've looked on clinicaltrials.gov, and calprotectin isn't measured. And it certainly wasn't used to drive the algorithm, so I suspect they just didn't measure it.
Yeah,
and it was across many different countries and sites, so that might have been, and it won't have been centrally. So yes, it will. Yeah.
So I'm now going to move on to the third of the P19s, gazelkamab, and I think I'm just going to show you one trial. That's the Vega trial, and the reason I think this is really interesting is because it's the first trial of combination advanced therapy that we've seen in ulcerative colitis. Now, there are two parts to the trial, as there often is. There's the induction phase and the maintenance phase. We did present the induction phase in the best of DDW, but I'm just going to rehash it here. And then the new data is the maintenance phase. So this took patients, again, relatively early in their disease course with ulcerative colitis, and they had to be naive to anti-TNF, P40 and P19 treatments, but they also had to have had an inadequate or intolerance to a conventional immune modulator or corticosteroids. And it randomized these patients to either anti-TNF monotherapy given as golimumab, to gazelkamab, the anti-P19 monotherapy, or combination therapy with both. And then the primary endpoint, which was clinical response, was assessed at week 12. And then after that, patients in the anti-TNF arm continued on anti-TNF. People on the gazelkamab monotherapy induction arm went to gazelkamab maintenance, and those on the combo therapy arm also went to gazelkamab maintenance. So there's no combo maintenance therapy here, it's monotherapy for maintenance. This on the left here is the data that we've already seen. Yeah, and I think, no, sorry, yeah, this isn't that. Although the primary endpoint was clinical response, this is clinical remission, the standard definition of clinical remission in ulcerative colitis. And I guess I would have to say I don't think we're seeing particularly impressive clinical remission rates for either as monotherapy, given that it's week 12 with no placebo, just over a fifth of patients reaching, but you definitely do get an uptick with combination therapy, perhaps twice the benefit when you're looking at the hard endpoint of clinical remission at week 12. So there definitely is an advantage of combo therapy. And then when you look across the maintenance arm, that benefit of combination therapy is maintained. So you do better if you were on combo for induction and then guselkumab for maintenance, then guselkumab all the way through.
Why do you think they were scared to do it through to the end of maintenance?
Well, I suspect there was a concern that an uptick of side effects in a combination trial would be very negative for the clinical development of the drug, which is going through phase 3 trials at the moment.
Yeah.
And then looking at other endpoints, endoscopic improvement, which is a Mayo of 0 or 1. Again, you can see a real benefit of the combination. This is in the end of maintenance, endoscopic normalization, histo and endoscopic improvement, same sort of thing. I think if I had to sort of say, what do I actually think about this? I guess I think I was slightly disappointed by the fact that the magnitude of benefit of combination therapy wasn't perhaps as great as we might have wanted it to be. Maybe that reflects the fact that they didn't continue combination through the maintenance arm. I think the one thing, and we don't have the data in this presentation, but the one thing that I thought was quite striking and does potentially show a benefit of combination therapy is they did RNA sequencing of biopsies looking to see which pathways were significantly impacted by either of the monotherapies versus combination therapy. And what I thought was really interesting is that, and I can't quite remember the exact figures, but let's say there were 400 genes affected by golimumab and 400 different genes affected by guselkumab. There were many times more affected by the combo. So it was, 4,000 or more genes. It was a step change difference.
An order of magnitude, at least.
Yeah,
in fact, wasn't it?
And I can't remember the exact figures. But what that's telling me is that although, and maybe in this trial clinically we haven't seen the benefit, combination therapy certainly immunologically has a much more marked benefit than either monotherapy alone, much more than just a simple additive effect of the monotherapies.
And I think the other thing to say, James, of course, is that you have to start somewhere, and this is the other key slide. That if you're going to combine advanced therapies, then you have to have a very close eye on safety. And I'm not surprised by this.
No, and what this shows us is that, and obviously this is through the entire trial. So this is taking people who had golimumab all the way through, people who had guselkumab all the way through, the P19, and then people who had 12 weeks of combination followed by guselkumab. And as you read across, there really is absolutely no difference in the side effect profile. So you're not actually having an adverse effect with the combination therapy. There's definitely a signal of benefit, perhaps not quite as much as we might have wanted, but immunologically a very exciting signal of benefit.
And again, this is anti-TNF, okay, which we've been using for a long time, in combination with a P19 antibody, which we think is a really safe way of treating people. And yet we've been combining anti-TNF with azathioprine
for a very long time. So I think the safety is very reassuring. Yeah.
So it's not that surprising, but it's terribly reassuring. Okay, I might just quickly flick this. Look, all these have come in now. Lots of questions. Good. Any of these medications used in combo with thiopurines, I assume not, as we don't routinely use with UST. Okay, I don't think we did mention it. In general, in most of the drugs that we are talking about, either thiopurines weren't continued, or there's no great logical reason because they're not hugely immunogenic. We haven't got there yet, but of course, one of the JAK inhibitors, filgotinib, in the selection studies, you were allowed to continue on azathioprine.
Yeah, and that didn't actually show any benefit in terms of efficacy or any risk in terms of side effects.
And remember, other JAK inhibitors in rheumatology given with methotrexate.
Yeah, and I think in this trial in Vega, no, people weren't on immunomodulator, although in the other combination trial that's been presented in Crohn's disease, the Explorer trial, that was vedolizumab, adalimumab, and methotrexate, and in some patients, some steroids as well.
Yeah, mega combination.
So this is a question from Shahida. What was the rationale for combination therapy at induction? Well, I think the logic of this was about giving people dual mechanism to really try and switch off the inflammation. And I guess the theory was that if you use an anti-TNF combined with an anti-IL-23 for induction, you're going to get more people in remission, and then they switch to the safer agent or the theoretically safer agent as monotherapy, guselkumab.
Cronis, is there any data on immunogenicity, anti-TNF immunogenicity with combo with USTI? And I don't think they presented that data. It's something I've been wondering about for a long time. But it's a very good question, and I suspect they must have done immunogenicity. But remember, of course, it's golimumab, and it's not a very immunogenic compound.
Yeah.
So I think when Mark Saman did the drug levels and antibodies, I'm not sure we ever found them. So we may not get it from that trial, but we might get it from other trials like Explorer.
Yeah.
Yeah.
And then a question from Stuart. Yeah, I think it's a really good question. They downregulated 4,000 genes, but only 40% of patients responded. What does that tell us? Good question. I guess it tells us that there are many redundant pathways in inflammation. And I guess it also tells us that maybe if they had continued with combination therapy for longer, they would have got better results. But I think I think that's a very worthwhile point, Stuart, actually.
So back to the fun, anti-lymphocyte trafficking. So we're going to talk here about vedolizumab. This is a study done across the Low Countries, being led from AMC, and was trying, I guess, to replicate or to understand whether early treatment with vedolizumab in Crohn's disease was more effective than later treatment, as we've seen, for example, with anti-TNF therapy. So we've actually seen data from Love CD before. The difficulty was they had trouble recruiting to the study because I think they got lots of people into the non-early arm, and they were struggling to get people into the early arm. And what did they mean by early? Well, they meant Crohn's disease that had been diagnosed for less than 2 years and only treated with a corticosteroid or an immunomodulator, whereas late was Crohn's disease for more than 2 years and immunomodulators and anti-TNF in addition to corticosteroids had been used. And if you look at the middle bar there, they had to have moderate to severely active Crohn's, standard definition of greater than 220, with the presence of ulcers. So they had a centrally read colonoscopy at the start. They had standard 026 induction. They were allowed an extra dose at week 10, which of course was not common in many of the early vedolizumab trials. And then they went on to 8 weekly from week 14, corticosteroids tapered by week 26, and another colonoscopy at week 26. You see it goes on to week 52, but these data relate to week 26. What did they find? Actually, just come over to the right-hand side here first. Endoscopic remission defined as an SES-CD of 0. They found in 45% of patients with early disease, but only 15% with late disease. And then if you instead use the definition of an SES-CD of less than 3, and remember one aphthous ulcer gives you an SES-CD of 3. So basically, this is ulcer-free colonoscopy. They see in 66% of patients and a third of patients who had later disease. And then if you combine that over on the left there with steroid-free clinical remission, again, a standard definition with endoscopic remission, then you see that half of patients in the early group are achieving that. I think it tells us a couple of things again. Early disease responds better than late disease to biologic therapy. I do wonder just how severe these patients are as they head into the study. And I think, when you think about people going into these sorts of studies and you think about it as an investigator, and you're presented with a patient who's got rip-roaring Crohn's disease, and you can say, well, do you want to put them into a study of vedolizumab? I think there will be a recruitment bias there.
And of course, with this trial, I mean, there are two factors that drove the position you're in, not just the earliness of disease, but also the previous exposure or not to an anti-TNF.
Yeah, absolutely. But nevertheless, impressive endoscopic data for a drug, that perhaps really has not got the biggest rap in Crohn's disease. So, and definitely reinforcement of that important point: treat early for better results. We're going to move on to JAK inhibitors now. A very brief overview that shows, of course, that there are 4 JAKs, JAK 1, 2, and 3, and TYK2, that together are important in transmembrane signaling through a variety of cytokines, and the cytokines that signal will utilize different receptors that are associated with different JAKs, and therefore when you think about your different JAKs and their specificities or selectivities, then you will see difference in terms of potential efficacy, but also difference in terms of side effects. I think the other thing to say is, when we're thinking about some of the more selective inhibitors, and we'll talk, for instance, about upadacitinib, and of course filgotinib is also JAK1 selective, we have to remember that as you increase the dose, they become less selective. So whilst tofacitinib is probably the least selective of the JAK inhibitors available to us, the others are not specific. They are just more selective towards one JAK rather than another. But since we mentioned tofacitinib, let's start with that. And I really quite like this abstract, which came from Maria Chaparro in Spain. And the reason I liked it is because it's a real-world cohort. They looked at about 400 patients across, I think, from the ANIDA registry, which is a really good Spanish registry. And they looked at these patients. They all had active disease at the start, and there's a real-world cohort of patients who they've treated with tofacitinib. And I think what I'd really like to point out here is that top red outline, and that is 30% of these patients had either cardiovascular and or thrombotic risk factors. So
they're pretty much the patients we're trying not to treat with tofa.
Right, feisty treatment here, and perhaps not surprisingly, you'll see they are all also pretty much anti-TNF exposed. Many of them also exposed to vedolizumab. So 92% anti-TNF exposed, 73% vedo exposed, and a few USTI exposed patients as well, with an average of two biologic patients at baseline. Severe endoscopic activity of 55%. Tricky treatment refractory cohort with risk factors. So what's the real life outcome? Well, you can see that over about 2.5 years, 50% of the patients stayed on drug. And the main reason for discontinuing, if you look at the orange box over on the right here, was either primary non-response or secondary loss of response, with only 16% having adverse effects of interest. And again, I mentioned this earlier, and it's something I just don't really have a feel for yet. What do you do with your JAK failures? And you can see lots of these patients went on to ustekinumab, probably because they'd already been exposed to anti-TNF and to vedolizumab. But clearly, ustekinumab was being tried, and I have tried it, but not in enough patients, I think, to have a really good feel for it.
I mean, I think the really interesting question would be what happens. Do tofacitinib non-responders or loss of responders respond to an alternative JAK inhibitor?
That's definitely an interesting question, and in fact, vice versa. And then moving on, just looking at dose escalation. Is this going to animate? It does. Good, yeah. And so this is just showing that 66% of patients who relapse, 66% of them underwent dose escalation, and 60% of them reached remission. So dose escalation recaptured about 2/3 of patients. And you can see over time there, a significant number of patients did undergo dose escalation. But perhaps the most interesting slide of all is the safety data based on those 30% of patients with risk factors. And you can see here, 3 patients had cardiovascular events, 2 patients had a PE, 2 patients had DVTs. And I think in a cohort of 400 patients with that amount of comorbidity, this is probably what you'd expect to see almost whatever you put them on, and probably less than if they had no drugs at all, because their active IBD would have driven these side effects more than anything else.
Yeah, I mean, I think it is quite reassuring data. And of course, that's pretty much what the European Union has concluded with the crack analysis, which is that they're not limiting the use of JAK inhibitors in Europe to only multi-biologic failure patients. You can use them first or second line, with the only caution being in people over 65 or those with significant risk factors. But even, I mean,
good old EU.
Yes.
What a sensible decision, or EMA, we should say.
EMA. Yeah. And so I'm going to move on to one of the other JAK inhibitors, and that's upadacitinib. And we've got a couple of data on ulcerative colitis, and then a couple on Crohn's disease. The first I'm not going to spend too much time on because effectively it's just a larger cohort of a trial that we've already seen. The phase 3 trial for upadacitinib in ulcerative colitis was powered assuming that not quite as many people would respond to the induction dosing as actually in the end did, so they could get their maintenance readout before they'd finished with all patients who had been going through induction. And so they then rolled the study to its complete endpoint, which included about another 220 patients. So patients with active disease, 8 weeks, 45 milligram upadacitinib, those that responded randomized to either 15, 30 of upadacitinib or drug withdrawal to placebo. And what you can see here is this is the previous analysis. This is what's given the drug its license for ulcerative colitis, both in the US and in Europe and the UK, a very strong induction and then maintenance signal. And then this is the larger analysis, and all you can see really is the larger analysis doesn't really give us any differences, and exactly the same when you look at the harder endpoints in terms of endoscopic improvement, endoscopic remission, and histological improvement, mucosal healing being a combination of endoscopic remission and histological remission, the hardest endpoint they have. It's clear evidence of benefit across the range in terms of endpoints. And then in terms of the side effects in this much larger population, again, nothing really that we weren't expecting. We're looking here in terms of events per 100 patient years. The number of patients included is shown at the top, about 250 in each. You can see that there is no real signal for serious infections, but there is when you break it down into herpes zoster, with the drug showing obviously more herpes zoster shingles reactivation than placebo. There were a couple of malignancies, none that were particularly obviously drug related. Likewise, there wasn't a particular signal here in terms of non-melanoma skin cancer, although the only cases that did occurred in the higher dose. So I think that's something we definitely need to watch. And there were very few venous thromboembolic events, but there did occur in those receiving drug. You'll see down the bottom here the elevated CPK, and that is something to watch out for. Patients do have an elevated CPK. The next is again, it's one of those slightly nuanced definitions, but it's trying to give us some sort of idea about how do we handle that post-induction responder maintenance dose choice. What happens to patients who go down to the lower dose, 15 milligram once daily, then lose response and escalate back to 30. And as you can see here, there was a whole range of different ways that people could get onto this open label 15 milligram once daily. They could have been in the phase 2 induction trial. They could have been in the phase 3 maintenance trial on any of these agents in a blinded fashion. They'll have gone on to 15 milligram as their first home in the open label extension. If they then had an inadequate response to the 15 milligram, they've been escalated to 30. So it's looking at the question, if someone flares on 15, what happens when they go up to 30? And this is looking 1 year after that. And what you can see here is sort of, I guess, is perhaps not as reassuring as you might want it to be, in that, yes, people do improve when you go back to 30, but not everyone does. And I think that that's going to give us a very challenging, I don't think it helps us answer the question of when someone's responded to 45, should they go on to 30 or should they go on to the 15? Because what this is telling us is that people who flare on 15 don't always get better when they go to back up to 30. And I still think we are not quite there at knowing what the right dose is for individual patients at maintenance. Certainly, we saw at data presented at DDW that those who were markedly anemic or had an extraintestinal manifestation, they did markedly better on 30. But here what we're seeing is that not everyone improves. So, a chunk of people do, but not everyone improves. Now I'm going to show you a little bit of data from upadacitinib in Crohn's disease. This is the second of the induction trials. It's called the UEXCEL trial. It included patients who were both bio-naive and bio-inadequate responders. Again, 45 milligram induction dosing over the course of 12 weeks compared to placebo. Very importantly, all patients had to dose to taper steroids during the induction. There was a forced steroid taper during the induction. That's slightly unusual. Responders went on to the maintenance study. And what you can see here, using again one of the two definitions for clinical response, clinical remission, a nice signal of benefit over placebo, and then endoscopic response, a fall of SESCD of 50% or more, a really very robust signal of benefit. I think what we're seeing here is that you begin to see an impact by about week 2, maybe slightly more impact at week 4, and then you get the main impact at week 12. So perhaps not quite as fast as we've seen in ulcerative colitis. But we don't have the patient level data yet. And then when you look at corticosteroid-free remission, as would be expected from the protocol, the majority of patients who achieved remission were corticosteroid because there was a forced steroid wean. Then finally, the hardest endpoint, endoscopic remission. And I think that is quite impressive. 30% of patients in endoscopic remission at week 12. And as you can see, because of the robustness of the definition, a strong delta above placebo. Adverse events, as you might expect, not much difference in the total number of adverse events between placebo and upadacitinib. Perhaps a signal that some of the adverse events related to study drugs slightly higher in the upadacitinib group, worsening of Crohn's disease, as you might expect, worse in the placebo group, and then interestingly here, an increase in anemia in the Crohn's disease population at the 45 milligram dose. That might just suggest a degree of lack of specificity, or sorry, lack of selectivity of the drug at that higher dose, impacting on some of the other JAK pathways, and a slight signal for zoster, and as mentioned before, CPK elevation, something to watch out for. Now, I think this is the first time we've presented this data, which is the maintenance data. So this is looking at both the induction studies. UEXCEED was all bio-refractory. UEXCEL, I've just presented a mixture of bio-refractory and bio-naive. Responders to the 12-week of induction went into the maintenance arm, and they were re-randomized to placebo, 15 milligram or 30 milligram upadacitinib, with the co-primary endpoint of remission and endoscopic response at week 52. And what you can see in the randomized responders, again, is a lovely signal of benefit, with just about half the patients in clinical remission, slightly more on the 30 milligram than on the 15 milligram, but both having a strongly significant benefit over drug withdrawal placebo. And of course, here you're not seeing those high placebo responses that we saw with the P19s, because this is a very fast onset, fast offset drug. And again, a nice endoscopic outcome data. And if we look at the harder endpoints, endoscopic remission, clinical and endoscopic remission, again, you can see a strong signal of benefit. So I think upadacitinib is going to be the first JAK inhibitor license for Crohn's disease, and my understanding is a nice submission is planned for sometime first half of next year. In terms of adverse events, just a couple of things to highlight here. As you would expect, slightly higher zoster in the higher dose upadacitinib. The CPK elevations. I think acne comes out somewhere. I can't see it here, but it did seem to. It comes out on one of the slides. Patients do tend to complain of acne with long-term JAK1 inhibition, and I think that's something just to bear in mind. And there was one thromboembolic event. Pete.
Okay, let's finish off with JAK. We won't spend long on this. In fact, one of the interesting things about this is it is not necessarily the drugs, although they are interesting, but the study design, and it's what's called an umbrella study, which I think we've seen more of probably in oncology, and I think this is the first one we've ever seen in inflammatory bowel disease. And it's basically taking a cohort of patients, and then they can be on more than one drug. It randomized to more than one drug in the study. There's more than one drug being investigated, and the two drugs being investigated here are ritlecitinib and brepocitinib. Ritlecitinib is a combined JAK3 TEC inhibitor. TEC is a TEC tyrosine kinase inhibitor, so another kinase basically. And then brepocitinib, as you can see, is a TYK2, which is a bit sort of IL-12, 23-ish in its flavour, stroke JAK1 inhibitor. And these were patients obviously with ulcerative colitis, and they were randomized, as you can see, to either ritlecitinib at one of 3 different doses or brepocitinib at one of 3 different doses, 4 to 4 to 4 to 1, placebo being 1. So in other words, 12 to 1, which will have an interesting impact on placebo rates, because basically people are going to assume they're on drug. But then after that 8-week induction, they then continued on chronic therapy at a single dose, as you can see there, whichever dose they were on in the induction study. So let's just go through to this slightly complicated slide and talk through it. So on the top you have ritlecitinib, and on the bottom you have brepocitinib. And I think the first thing that you can see without really looking at anything at all is there seems to be a dose response there quite clearly across both drugs. And the second thing you can see is that it works in induction. So we've got 3 different outcomes here: clinical remission, modified clinical remission, and endoscopic improvement. And then you've got week 8 first and week 32 second, which is why you've got an extra sort of bar there in week 32, because the placebo patients start getting treated with drug. And I think you can see quite clearly that the drugs work both in induction and in maintenance, and clearly where we need to go from here is phase 3. Yeah,
I mean, I think it's striking, a 0% placebo rate, very robustly performed trials.
And goes very much against what I said at the start, that when you randomise people 4 to 4 to 4 to 1, you'd expect a higher placebo rate. Anything. So anyway, never mind. And then again, I think I'm not going to go into these side effects here. I think there's very little you can take away from a small phase 2 study on side effects.
So no concerning signals.
No, nothing huge. No.
And I think maybe we'll just take a quick break, see if there are any questions. Yes, there are quite a few.
Lots of questions.
Okay. Yeah. So first a question from Stuart: vedolizumab good in colonic Crohn's disease. What about small bowel disease? That's a really good question. Obviously, LOVE-CD predominantly. Did that include predominantly colonic Crohn's? Don't know.
I don't know. Yeah. I don't know the answer. I think, if you look at some of the other studies with what was the open label vedolizumab mucosal healing study?
I'll think of it in a moment.
I can't remember. But anyway, that certainly showed that colonic disease was easy to treat. But I think we see that across Crohn's disease, don't we? Colonic disease in Crohn's disease is easier to treat than small bowel Crohn's disease.
And of course, the trouble with the LOVE-CD approach is that currently vedolizumab is not approved by NICE as first-line treatment in Crohn's disease for our practice.
That's very true. That's very true indeed. So what about the real-world study here? Do we know if it differentiated side effect risk between the 5BD and the 10BD group? No, it's a very good question. And of course, clearly you would expect the 10BD group to have a higher side effect incidence. So I've not seen those data. They didn't present those data, but you would naturally expect that to be the case. And once escalated, did they remain on escalated dose or cycle back down? Another fantastic and very important question. Certainly my experience is often those people that you dose escalate, even though label now tells us we have to bring them back down again, they're not easy to bring back down. And again, I don't think they actually presented these data as such, but it is, it's encouraged to try and dose reduce again, isn't it? But I don't think it's terribly effective.
Shahida, great question about the JAK inhibitor trials. No, they didn't exclude patients who'd previously had zoster or shingles. And what does it mean in terms of should everyone be having shingles vaccine? That's a great question, and it's one that I don't suppose many of us have necessarily bottomed out. Clearly, Zostavax, the original vaccine that's available, is not appropriate because most patients are going to be immunosuppressed and it's a live vaccine. We are just getting access to Shingrix in our area. From a primary care perspective, it's available for people over 70, which isn't really that useful for our patients. And we are trying to get on top of who we can and how we can access it for our younger patients who are immunosuppressed. But yes, I mean, there is, in an ideal world, I think people would have Shingrix vaccine.
Yeah, absolutely.
If we could access it. Its slight problem is it's £300, and it's persuading. It's 2 doses of 0.5 ml, 8 weeks apart. You can prescribe it privately for patients if they want to pay. We are having very patchy access to it. Some GPs seem very happy on the basis that it's an immunosuppressed patient. Others are kicking back, saying there are no guidelines. Of course, they're absolutely correct. There aren't any guidelines.
I'd gladly pay that not to have
bad shingles.
Yeah. And then, Stuart, do try to routinely look at the 50-70% who do not respond to get clues as to what differentiates responders. So in the actual clinical trials, I don't think they do look at them. Of course, and it depends because, of course, if you look at the upadacitinib trials, it wasn't 50 to 70% who didn't respond, was it? It was much less than that. But anyway, that's not the point you're making. So one of the things they do, of course, is they have extended induction, don't they, in most trials now. And I think of the patients who don't respond to initial induction, you will often see about 50% of them responding to extended induction, although that's not placebo controlled. So you have to take that with a pinch of salt. That whole, can we identify what makes people non-responders and what makes people responders, other than perhaps their previous failure of biologics, the severity of their active disease.
Isolated ileal disease and Crohn's disease.
Yeah.
That's a predictor for non-response.
Yeah. I think generally we're spectacularly poor at knowing which patients do and don't respond. So S1P receptor modulators. So you'll all be familiar with this this schematic of how S1P receptor modulators supposedly work, although many people don't believe the hype, if you like. Nevertheless, the theory is that S1P is a chemical that is expressed in the lymphatic system and is used, if you like, by lymphocytes to be dragged out of the lymph node along an S1P gradient using their S1P receptors on their surface. And of course, what the S1P receptor modulators do is modulate that by internalizing the receptor. And so I guess they're less sensitive to that S1P gradient and therefore become trapped, if you like, in the lymph nodes. There is a little bit like JAKs. There's a number of different receptors and S1Ps involved, and these are associated with different effects and side effects. And the two drugs that we have available or almost available to us in inflammatory bowel disease, ozanimod and etrasimod, generally have pretty good side effect profiles based on that. So as was just really alluded to by James earlier, by Stuart in that question a moment ago, what we see is that patients who have failed to respond to I'm just slipping onto the next slide here because I realize I'm talking about the wrong one. Patients who failed to respond to induction in the ozanimod trials went into an extended open label induction, and what we saw there is that after that first 10 weeks, if you had a second 10 weeks, then you had about, as I said earlier, about a 50% chance of responding to extended induction. Of course, as I said earlier, these are not placebo-controlled patients, and so you have to take that with a pinch of salt. But I think one thing that's interesting here is if you have ozanimod patients who haven't responded after week 10, after 5 weeks of extended induction, you capture 44%. But adding on another 5 weeks, in other words, going out to 20 weeks overall, you don't really capture many more. So I think what that tells us is if you are going to give extended induction, probably if they haven't done anything by week 15 overall, they're probably not going to do anything. And I'll go back to the slide before, which I was stumbling over looking for the data on it that I couldn't find. And this looks to patients who have been withdrawn from ozanimod and then retreated in open label in the clinical trials. And what we can see here is, again, that you'll recapture something like 50–60% of patients when you retreat them with ozanimod after they've lost response when they were treated with placebo. And interestingly, not much difference here with patients who have been exposed to biologics or not exposed to biologics. And I think, we've seen before data that shows that with increasing biologic exposure, ozanimod becomes less effective, perhaps not surprisingly, as many drugs do. But once you've responded to it, it stops mattering whether you're a biologic exposed or a non-biologic exposed. The drug works for you, and it kind of works in the same way.
One important thing is that one of the reasons why, particularly with anti-TNF, loss of responders is, of course, as immunogenicity drives response, and if you develop drives loss of response, and if you develop anti-drug antibodies with one anti-TNF, you're more likely to develop anti-drug antibodies with the other anti-TNF. Whereas, of course, that doesn't affect any of the small molecules, be it ozanimod, filgotinib, tofacitinib, upadacitinib. None of them are likely to have issues with that as a mechanism of loss of response.
Right. A little bit of, since ozanimod is now out there and we can prescribe it and it's NICE approved, a little bit of practical stuff as well from the clinical trials. Hepatic abnormalities do occur in patients on ozanimod, but they tend to be mild, they tend to resolve, and they didn't tend to lead to people withdrawing from the studies. So a manageable blood test side effect, if you like, rather than a serious concern, I think. And then briefly, very briefly, because we're nearly at time, aren't we? Etrasimod, as I mentioned, this is the other S1P receptor modulator that's entering the latter parts of phase 3. Again, treatment here in ulcerative colitis. Both drugs are also being trialled in Crohn's disease, although they're a little bit behind. And you can see here, we see 2 induction studies, one of which continued in a treat-through manner to week 52. That's Elevate 52. And the second induction study, Elevate UC12, which actually, as this schematic suggested, started later on. And that might be one of the reasons why we saw a bigger placebo response in this study, because by this time, many investigators felt the drug was working. I think that biases who goes into the study. I think it biases what people say to patients, and I think that explains that. So if we just look, I'm afraid this labeling is slightly wrong. Over on the left-hand side there, we have Elevate 52, and you can tell that's the case because here's week 52 data. And we can see a really good delta over placebo here when we look at clinical remission at weeks 12 and 52, 27% of patients in remission with a delta of about 20% over placebo during induction. And then out at week 52, and remember, this is not re-randomization of responders. This is treat through and a delta of about 25% over placebo there. You can kind of try to model a re-randomized responder type thing. I think they did it in C-view actually, and of course then that gives you a feel more for how to compare yourselves. But I think it's dangerous to do that sort of thing.
I mean, I think what you can see, it's an effective drug,
right?
Both at induction and maintenance.
I think we'll move on past here because this is a hugely complicated slide, and we're running a little bit further behind tonight than we were the other night. Basically, just as with Ozanimod, the benefits of S1P receptor modulation with etrasimod are less clear in people who've failed multiple biologics and or JAK inhibitors, which again is not a huge surprise to me. Oh yes, okay, I think this is worth mentioning as well. And again, a practical point, and that is that you see a drop in the peripheral lymphocyte count associated with the use of these drugs, which is not hugely surprising given the mechanism of action. There's not, however, a huge relationship between the lymphocyte count and side effects, and in particular, infective side effects. There also isn't actually, it doesn't seem to be a particularly good pharmacodynamic marker actually either.
It doesn't correlate with efficacy.
Which is a bit of a shame actually.
Yeah,
but I mean, still.
One of the things to remember this is that these patients are going to have lymphocyte counts that are going to click up on GPs monitoring. So I mean, there does need to be some communication between us and GPs on patients with on Ozanimod or etrasimod that we don't need to be as concerned about the lymphocyte count, because these will definitely click up. The lymphocyte counts fall quite dramatically, as you can see.
It's not the same as the lymphopenia that we saw and see with thiopurines.
No, certainly at the moment we don't have evidence that it correlates with side effects in the way that we do with thiopurines.
Yeah, agreed. So
I think there's only one more study that I wanted to show, and really I'm only showing it because it's a mirror of a study that Sarah McCartney, myself and colleagues with Seb Shahi in Hull did in transition, and that's looking at the benefit of a pediatric to adult transition program. This is Spanish data. Have to be honest and say their study is bigger than ours was, but they look to evaluate the plan versus and structured transition program compared to none, and to know what percentage of patients were lost to follow-up. Like ours, it was a retrospective multi-center non-interventional trial. They had two groups, patients who were transferred between pediatric adult services over 3 years were included, and they excluded patients with less than 1 year follow-up. And really, it just is here to show you pretty much identical data, bigger trial, but identical data, less frequent emergency room visits in the transition compared to the non-transition group, less frequent IBD flares, less frequent steroid use. Again, highlighting the benefit of a structured transition program. And I think that's our last slide. So we're just going to have a quick peek to see if there are any final questions.
Varsity.
So someone saying no, it wasn't Varsity.
No, it wasn't.
It was the clinical trial.
No.
It's the
Varsity was
not Love CD.
Varsity was vedolizumab versus adalimumab. It was
the dedicated mucosal healing trial of vedolizumab. We'll think about it, and yeah, I'm sure no one's that interested. It's just irritating me. I can't remember its name. I guess what have we shown in this in our talk? Well, we've been through the cluster randomization trial REACT-2, and we've talked through some of the issues with doing treat to target trials, how you've got to be very careful about the population you select and what that means for the future use of it. Obviously, Pete showed with ultrasound the harder, and I think we've shown with loads of trials, the more robust the endpoint, the better people do in the longer term. And ultrasound might be one way that we can access that in a more patient-friendly, and certainly patients prefer having an ultrasound much more than they do an MRI and obviously an endoscopy. We've shown quite a lot of data on new drugs, IL-23 inhibitors and JAK inhibitors. We've also shown data on the vedolizumab and on Peter's just found it's Versify, and on new and JAK inhibitors, and sorry, on the S1P inhibitors. I think that's the end of our run.